So I'm going to change a little bit and look at shifts in grade and stage of prostate cancer that we've seen in our institution at the level of prostatectomy using a whole mount analysis. And I'll tell you what a whole mount analysis is as we go through. This is my disclosure. It has no effect on the bearing of the information I give now. The prostate cancer landscape has definitely changed. Now, I'm talking about a 16-year study that we're going to be doing here. So let's look at all the changes that have happened over time that could affect things over that. First, we saw, it has already been presented, there's been a shift in the clinical presentation of prostate cancer, largely due to the PSA era. Over the course of the 90s, and into the 2000s, we've been seeing earlier stage disease and lower PSAs. This is data that comes from the Department of Defense, and we look at the decade of the 90s here, and this is clinical T stage at the time of prostatectomy, and we see a notable increase in T1 disease, a drop in T2, T3 remained pretty much the way it was. Look at what happened with PSA level during that same decade. We see a lot more tumors being diagnosed with in the PSA range of 4 to 10, and even under 4 has risen during that decade as well. There's been a shift in screening. We've already talked about this. We recognize that we were over-treating biologically indolent tumors, and in 2012, PSA received a D rating. Now it's been up to a C rating, but the damage has been done. What are we seeing now is a recent decline in prostate cancer diagnosis. You saw this earlier with Dr. McLaughlin's data. Here's the SEER data, very similar. There's the bump, there's the little peak during the PSA introduction phase. But what we're seeing over the last years now is a steady drop in the number of patients being diagnosed with prostate cancer, and a precipitous drop starting about 2010, to the point where now we're seeing diagnoses about the same rate as we saw in the mid-'80s. There's a shift in treatment paradigms. Active surveillance has raised its head. Targeted focal therapy, we've mentioned, for low-grade cancers. But we're also seeing an increased use of radical prostatectomy for high-risk disease here. This is data from the CAPSURE registry. They look at CAPRA score as an index of risk here. So your low risk is your CAPRA 0 to 2, intermediate and high-risk disease. And these are the various treatment modalities over these time periods that you see here. If you look at the low-grade, the low-risk tumors here, since about the 2010 to 2013 period where this was drawn from, you see a marked increase in active surveillance. What used to be pretty low is now up to about 40% of these cancers being treated by this modality. If we look at the other side, these high-risk diseases here, in the same time period, we're seeing a doubling of the number of high-risk disease that is going to radical prostatectomy rather than primary ADT, for instance. And as I've already shown earlier in my discussion a couple hours ago, there's a shift in pathologist grading practices, largely due to the ISUP 2005 and 2014 consensus conferences. And that has caused a shift towards high-grade grade shift, if you will. This kind of represents the new map that is used that shows a much more stringent definition of Gleason pattern 3 and shifted a lot more things into the 4 and 5 category. And I showed this data earlier that shows that we have seen a grade shift using these new parameters here. This is a group out of Canada that showed that before the ISUP 25, that almost 70% of their cancers were Gleason 6. That dropped to almost half, and there's a notable increase in Gleason 7 and 8. And even in the prostatectomy Gleason scores, we see the same phenomenon. This is the Harvard study. I also showed this data earlier, where you can see that there's been a shift. This was the original grade here, and when they were regraded, everything shifted up. So there were much more 3 plus 4, 4 plus 3, 8s, and 9s after regrading using the new policies. So we have all of these things going on kind of all at the same time. It's a big soup now. So we asked the question, has this all had a huge impact on what we're seeing at the prostatectomy level? And the answer is, of course, yes. Here's what we thought. Going into looking at our study, we said, well, certainly ISUP grading has caused a shift towards higher grade tumors. So we're going to see a shift towards higher grade going in our prostatectomy specimens. An increase in active surveillance, well, we hope that'll produce a decrease in the amount of low-grade cancers going to surgery. That's what you want to do, is avoid surgery in these patients. and put them on active surveillance. So we would see a relative but proportional increase in higher grades. But what about this decrease in screening? What about the fact that we're not diagnosing as many patients as we used to? What will the impact be there? Will we see another drop in low-grade cancers? That's what the idea was to drop this and not overtreat these low-grade cancers. But will we see a disproportional increase in high grades? Are we going to be catching tumors later in their natural history that results in more high-grade and high-volume tumors, in stage tumors? And we didn't know this going in. So we looked at our University of Colorado prostate cancer database. This database is significant because all the prostates were whole-mounted, and I'll show you what that means in a moment. They were limited in that only 2 pathologists, myself and my colleague, Dr. Francisco La Rosa, did the grading on all of these. And we tend to show each other our cases and agree on our grades. So these are fairly uniformly graded by a limited number of pathologists. And grade, stage, and tumor volume can be more accurately assessed on a whole mount study. So those were powerful things that we relied on. What is a whole mount? Basically, we take a prostate and we cut it like a loaf of bread, all the way from apex to base, here about every 4 millimeters, and we then use a special microtome to cut these so that you can mount the entire section on a single glass slide. Once you do that, here's a glass slide stained with hematoxin eosin, and we can go through and we can look at all the areas of cancer, dot them all out here. And as I'll show you, we can actually reconstruct these and put them back together and kind of get an idea of what it looked like in the entire prostate. But by doing this, we get very accurate measures of volume and grade distribution within them. So here's our data. This is what's happened. This is prostatectomy tumor grade as graded by the pathologist at the time of prostatectomy. We haven't regraded anything here. We're just using the grades as reported over time, starting in 2002, going all the way through. And what do we see? Well, we certainly see a decrease in the number of Gleason score 6 and below cancers going to prostatectomy. And that's good. In fact, in 2017, there were none. No Gleason 6s were graded on prostatectomy. And we see an increase in the number of high-grade tumors that we see here. Gleason 9s really went up, but also 4+3s, 8s, we see that a big increase in that particular genre. Another way to look at this is a little bit more striking is to do a pie graph. And we could take a pie graph of the low end and the high end and kind of compare it. Now, we combined 2 years here for the sake of numbers. But here's the beginning of our study, 02 and 03, and here's a pie chart showing the distribution of Gleason grades in our prostatectomies. You can see 40% of them at the time were graded as 3+3 on prostatectomy. Only about 4% were 9s and 10s. Here's what it was in the last 2 years of our study, 2016, 2017. Notable decrease in the number of Gleason 6 and below, only 2%, and all of these, again, were from the 2016 group. And notice the big increase, particularly in the red slice of the pie, from 4% all the way to 31%. Another way to look at it is do we see a proportional increase? Are we just removing Gleason 6s from this, so they're allowing everything else to expand within the pie? The answer is no. If you take those out, there is a disproportional increase in a number of high-grade tumors that we are seeing. From 6% now, if we took off all the Gleason 6 and below, to 31%. We are definitely seeing not just a grade shift here, we seem to be seeing really important disease differences in patients going to prostatectomy. Another way to look at that is to look at it with the matched biopsy. I think these data are really interesting. So these are matched biopsies. These are the pre-surgical biopsies that led to these prostatectomies. And we can see back then, look at that, almost 3/4 of the tumors you thought were Gleason 6 or below went to surgery at that time. And so there was a notable upgrading at the time of surgery. Not so much here. Only 8% of our cases actually had 3+3 tumor that went on to prostatectomy. Where were they going? Well, radiation therapy or active surveillance or something else. They were being treated elsewhere. And notice that we know now that, one, there's less upgrading in this system by doing that. So we did something right there. But we also know now for sure patients are being selected and going to prostatectomy with higher risk tumors. You know, a third of our tumors were Gleason 8s and above, known at the time and went on to surgery. And that's very different. So we're actually seeing more aggressive tumors at the time they go to surgery. And if you look at the mean cores positive, 2.5 back then, now 5, a doubling of the number of cores positive that we're seeing. And in all of these were matched only with tumors that were 12 cores. So these don't include our mapping biopsies that were alluded to earlier. So certainly mapping biopsies would increase the biopsy number, but that was not the case here. These are all 12-core biopsies. So we are seeing more advanced tumors going to surgery. Here's another way to look at it. Here's pathologic stage at prostatectomy. So this is the stage that we reported at prostatectomy. For a long time, it stayed level at about 30% of our cases had advanced disease, T3 and above. Notice this precipitous jump starting about the last 6 years here, starting about 2012 and up. It's almost 50% of our cases now are PT3 and above tumors. Look at our N1 tumors. They were less than 2%, actually 1.3% back in 2002-03. Now they're 8%. So that's a more than fourfold increase in the number of cases that are metastatic at the time of surgery. We are definitely seeing higher stage disease. I also mentioned another thing that we can do with our whole mounts, and that is that we can reconstruct. And what we do here is we take those H&E stained sections and we draw out things by grade. So we use a different color pen for the different grade patterns that we see. We can draw all of these out for every slice that we went through the prostate. And we can take those individual slices, then we can scan them into a computer. Computer goes through a bunch of filtering and processing conversion steps to put it in a situation where we can reconstruct it and put it back together again. So here's a reconstructed one kind of spinning around for you, shows a few things. One, you can see the cloud here. I hope that shows up. The cloud is the entire prostate, and there's a few things that are highlighted here. One is the blue. That's our internal reference. That's the urethra, taking its normal bend within the substance of the prostate there. So that's your internal reference point. And this particular prostate has two cancers. One, this low-grade cancer in red, sitting right up next to the urethra in the transition zone, and this other one in the peripheral zone in green back here. And, we can do this, and we can actually look at multifocality, tumor location, and grade status within them. My former mentor, Dr. Gary Miller, was the first to use this technology to look at carcinomas, and he looked at 151 prostates that were all pre-PSA eras. He published this in 1994. So this is all pre-PSA data that he's really looking at, and he showed at that time that prostate cancer was a multifocal disease process, because at that time, 56% of the cases had more than one tumor within the prostate. And interestingly, if you look at mean tumor volume, by far the largest tumors were in those prostates that only contained one cancer. Why is that? Well, he reasoned that this really didn't start out as one tumor. This is the fact that tumors that were multifocal grew to the point where they grew together and molded together into something that was inseparable, that you saw as one big conglomerate tumor. That may help explain why we see such heterogeneity in grade and molecular status within tumors of the prostate, is they simply don't start that way, they grow together. But look at the data down here. His mean tumor volume overall was almost 4.5 cc's at that time. We were seeing big tumors back then. In the multifocality, we were seeing about 1.9 tumor per patient if we did the math here. Well, we looked at the prostate cancer database using whole mount studies the same way that he did it, and we looked here in the PSA era, if you will. We did 10 years of the PSA era and showed that he was right, that if you dumb it down and catch tumors at an earlier stage than the pre-PSA era, that you increase the number of multifocality. It's gone from 56% of tumors multifocal to 72, with an average of 2.7 tumors per patient now instead of the 1.9, and the mean tumor volume dropped from 4.5 down to just over 2. Look what's happened in the last 2 years. In the last 2 years, we're still seeing multifocal disease here, but the number of tumors is starting to drop. It's decreasing, kind of about halfway between 1.9 and 2.7. Look what's happened to our mean tumor volume. It's gone way up, from a little over 2 to over 3.5 cc's. We're going in the wrong direction with this. And another thing that's a little puzzling to us, we don't have an answer on yet, is that anterior tumors, our index tumors being anterior, were a little over 20% during the PSA era, and it's increasing now. Now, we don't know if this is a statistical blip or if this is telling us something that's changing in the way prostate cancers are presenting these days, but we're seeing more anterior tumors than we used to before. So, in conclusion here, we're seeing a lot of changes in what we're seeing at prostatectomy, and there may be a lot of reasons for that. Clearly, there's changes in the clinical management, removing cases from low-grade cases using active surveillance is happening, but we're seeing more high-risk tumors being selectively taken to prostatectomy. But are we also catching tumors at a later point in their natural history? Because we're seeing a shift towards higher-grade tumors. Certainly there's an increased stage. You can't blame the pathologists. You can blame the pathologists for some of these high-grade tumors, but you can't blame the pathologists for the increased stage, node status, and larger tumor volumes that we're seeing here. We are truly seeing more advanced tumors. Now, what the impact on mortality is going to be, that's what David brought up earlier, we don't know yet. It's going to take time to answer that question and follow these and see if there's going to be an impact on mortality. Before I go, I would like to acknowledge the people who really helped do this study. My partner in crime is another pathologist, Dr. LaRosa. You've already heard Priya's name here. He actually helped invent the program that allows us to do three-dimensional reconstruction. Our statistician, Dr. Torko, Audrey van Bachhoven, who runs the biorepository, and a number of histologists who help make those whole mounts happen. Thank you very much.